So today's score topic is inside abdominal neoplasm and pain, but really it's about peritoneal neoplasms and pain. So quickly, a brief overview of the types of abdominal pain, the three different types. One is the visceral, the somatoparietal, and the referred pain. Visceral pain is caused by the visceral stimulation of the visceral nociceptors. Could be caused by inflammation, could be caused by distension or ischemia. It's classically a dull pain. Usually it's felt in the midline. And the transmitters are the sympathetic sensory fiber efferents which supply the sensation to both sides of the spinal cord. And that's the reason why it's actually felt in the midline, because you have signals going from both sides of the body to the spinal cord. It's usually poorly localized, and the site of pain is determined by which part of the gut the organ derived from. So if you have epigastric pain, classically the organs that are derived from the foregut would be responsible for that, such as stomach, duodenum. If the pain is more periumbilical, it's usually from organs that are derived from the midgut, and the classic example is the appendix, where the pain starts out in the periumbilical region and then moves to the right lower quadrant, which would be the somatoparietal pain. And then if it's the hypogastrium, that's where the pain is. Usually it's from organs derived from the hindgut. Somatoparietal pain, this is caused by the inflammation of the parietal peritoneum. It is certainly more intense, is more precisely localized to the area which is affected, and the lateralization in this case, because it's not in the midline, it's exactly where the irritation of the peritoneum is. The lateralization is possible because only one side of the nervous system is innervated by the parietal peritoneum. So again, classic example is your appendix. You start out with the visceral pain, which is periumbilical, which is caused by the distension of the organ itself, the appendix, and then once the inflammation extends to the parietal peritoneum, that's when the pain actually moves to the right lower quadrant. So that's a pretty classic example. And then there was this picture, again in your spore book. This is common locations of the visceral pain. Again, as we talked about, the organs which are derived by the foregut, stomach, pancreas, these will be the ones that you'll have pain in the epigastric region. Small bowel classically would be the periumbilical, and then colon, usually the colon, which is a left-sided colon, and the uterus will cause pain in the hypogastric region. So referred pain finally, felt in an area which is remote from the affected organ. The pathogenesis behind it is the conversions of the visceral afferent neurons combined with the somatic efferent fibers from another anatomic region in the spinal cord. Usually occurs at the level of the second order neurons in the spinal cord. Classic examples are the shoulder pain from irritation of the diaphragm, scapular region with the biliary tract disease, and testicular pain with any retroperitoneal inflammation. And there's a figure. As we talked about pancreatitis, referred pain in the epigastric region, cholecystitis, you may have pain in the shoulder region. Appendicitis will then get referred to the right lower quadrant as well. So peritoneal neoplasms, majority of the neoplasms are metastatic from carcinomas of other origin, including the GI tract, such as this, and the most common of those that will metastasize to the peritoneum are the stomach, the colon, and the pancreas. The GU tract, such as ovarian cancers, as well as some extra-abdominal cancers, including breast. Primary peritoneal neoplasms are relatively rare. Most common of these are the malignant mesothelioma as well as angiosarcoma. So 3 peritoneal neoplasms that SCORE wants us to discuss for today's topic are the pseudomyxoma peritoni, peritoneal carcinomatosis specifically from the colorectal cancer, and then the desmoid tumors. So the pseudomyxoma peritoni is usually mucinous ascites from a ruptured adenocarcinoma. Could be from the epithelial neoplasms of the appendix, or it could be from the ovaries, either one. Usually it's the appendix which is the most common. Peritoneum becomes coated with a mucus secreting tumor, and then subsequently the peritoneal cavity is filled with the tenacious semi-solid mucus. So epithelial neoplasms specifically, they're still categorized under the using the NCCN guidelines. Is the epithelial neoplasm of the appendix are still categorized under the colorectal cancer heading. 10% of the appendiceal neoplasms will develop pseudomyxoma peritoni. Usually occurs in patients 40 to 50 years of age. 1:1 male to female ratio. Symptoms usually occur late in the course of disease until you have the pseudomyxoma is sort of sufficient to cause abdominal distension or abdominal pain. And classically, in my fellowship, I noticed I had patients who would come in who were operated on for a presumed diagnosis of hernia, because they'll have pseudomyxoma going down. If they even had a small hernia, they'll go down to the scrotum. Then the general surgeon would see him, feel the mass, think that probably is bowel, and then they go in, they operate on the patient and realize it's all just pseudomyxoma. And that's when they'll take a diagnosis, tissue diagnosis, and then refer the patient for HIPEC. So this is one of the common, you could say, presenting symptoms. It's not really a hernia, but that's how they present, because they'll have a bulge in the groin. Yeah.
The question on that, in SCORE, one of the questions I think was an inguinal hernia being repaired, and then when they opened the sac, there was gelatinous tissue. Consistent with that, what proper management in that case? You just close it up. I mean, you don't put a mesh. You just.
I wouldn't put a mesh in. Do a primary repair. If there's clearly if you have a hernia sac, you'll have to reduce her just like you would, and then I would do a primary repair. And then worry about. You can let the patient know that there is a chance that might be a recurrence or whatever. But our focus is to get your cancer treated. Management, you have to get a CT of the chest, abdomen, pelvis to evaluate the extent of disease. And the important thing to assess would be if this is something that is resectable or not. That's the biggest question that you have to ask yourself based on the CAT scan: is it a resectable disease or not? And then you may even want to do a preoperative colonoscopy, because there are some mucinous tumors of the colon as well that can present in a similar fashion. And so you want to be absolutely sure that this is appendix versus a colon origin. So your preoperative colonoscopy is recommended as well. So patients taken to the OR for laparoscopic appendectomy for presumed diagnosis of appendicitis. On insertion of laparoscope, you see mucinous deposits all over the peritoneum. What's the next step? Amos, what would you do?
Take some biopsies of those deposits, send them off, and see what
Okay. Like, would you do a frozen section or just a permanent, or?
I would send it for permanent first.
Okay.
Because you're not going to do it at that time. You're going to close it off and then do pre-operative blood off afterwards.
Okay. Could you do an appendectomy or not?
I don't think that the initial, I'll try to find out where exactly it is first, and then we go.
Okay. Yeah, that's probably the best option is that, unless you have, most places will not be doing cytoreductive surgery in HIPEC. So if you're at a hospital which doesn't have the capability to, that's the best option. Take a tissue diagnosis, close. Usually in this setting, if you have mucinous deposits all over, it's probably from perforated appendiceal tumor. So not a good idea to even do an appendectomy because patient most likely will need a right hemicolectomy. So just take tissue deposits and close and refer, either come back yourself or refer the patient to some place which does cytoreductive surgery. So management for pseudomyxoma peritoni, it is cytoreductive surgery plus HIPEC. What does cytoreduction entail? Involves you got to do an omentectomy because that's the most common location of all tumors that metastasize or even for pseudomyxoma they'll spread to the omentum. So that's the first step that you got to do. You have to get rid of the omentum so you can then see the organs. In this case, you may have to do an appendectomy versus right hemicolectomy depending on the histology of the tumor, and we'll go over it in a little bit. So if it's one of those tumors that are not that malignant or have good prognosis and they're not ruptured, you can just do an appendectomy. But if it's an aggressive kind of tumor, then you need to do a right hemicolectomy because of the concern for lymphatic spread. And you got to strip the involved peritoneum. That'll be the next step. And then you have to resect organs. Most common organs affected in this setting is usually the small bowel and the spleen. You may have colon affected, and so you may have to take that segment out as well, or any other organ. Sometimes you may have to strip the diaphragm as well, or even take part of the diaphragm, depending on whether the muscle of the diaphragm is involved or not. So again, it could be, sometimes you go in and all you see is just gelatinous material that you evacuate, but no other organs are affected per se. You just end up doing a HIPEC. You don't have to really do a cytoreduction. But if you have other organs involved, you may have to resect before you actually do a HIPEC. So in terms of resection, ideally you want no residual tumor greater than 2 millimeters should be left behind to allow better penetration of the intraperitoneal chemotherapy, which would be the HIPEC part of this, the operation. So when you go in there, what are the common limiting factors that may preclude complete cytoreduction? Most commonly, it will be the involvement of the small bowel. So if you see like either the entire length of the small bowel is affected or say even 80% is involved, which would mean you'll have to resect 80% of the small bowel with only 20% left, that wouldn't be compatible with life. So at that point, probably not a good idea to even pursue it. We can just close. The other area that can be difficult to really cytoreduce would be the porta hepatis because of the critical structures that are present there. So if you don't feel like you can get a complete cytoreduction of the porta hepatis either, that's another reason, or any other area which you feel you can't cytoreduce for whatever reason. If there's an involvement of the blood vessels that may affect like the SMA or something, then again you got to stop and just close. The important biggest thing is complete cytoreduction, at least as we said, any residual tissue should be less than 2 millimeters. And then followed by HIPEC, which would be, the reason for HIPEC is destruction of microscopic tumor cells which you can't see. And the reason for hypothermia, they've looked at it and no clear reason why, but they feel there's better penetration of the chemotherapy with hyperthermia. Usually you'll actually have chemotherapy being heated up to 42 degrees and then circulated through the peritoneum. So it allows destruction of microscopic tumor cells. Complications, usually this procedure has a 2 to 3% mortality. And again, depending on where you are, if high volume centers would have a relatively lower mortality rate compared to low volume centers. Morbidity is pretty high as well, between 25 to 35%. Some of the common complication, most common, again this is probably a written board question, most common complication for HIPEC is a prolonged ileus. Other complications include an anastomotic leak, EC fistulas, you can have pancreatitis, neutropenia. Reason for neutropenia is the intraperitoneal chemotherapy. Cisplatin is one chemotherapy that's used and that can cause neutropenia as well as renal failure. So those are some of the common complications. And what are the contraindications for cytoreductive surgery and HIPEC would be, of course, inability to remove all the tumor to 2 millimeters or less. And the other thing you would need to consider would be the patient's functional status. They, this would be a big operation. If they're not, there are too many comorbidities, they may not be able to withstand such a big procedure. And this would be the classification we talked about. So it's the epithelial neoplasm of the appendix. It's the spectrum. You start out with the first type is the diffuse peritoneal adenomyosinosis. That is the low-grade tumor, and 5-year survival is 75%. In this case, again, if there is no rupture of the tumor, you can just get away with laparoscopic appendectomy. Then other end of the spectrum is the peritoneal mucinous carcinomatosis. This is a high-grade tumor. 5-year survival here is 14% as opposed to 75%. In this case, even if there is no rupture of the tumor, you need to do a right hemicolectomy because of the high-grade tumor, and there's a high chance that this may spread to the lymph node, so you need to do a right hemicolectomy with this kind of tumor. And then in between these is the peritoneal mucinous carcinomatosis, which is the intermediate type, has a 5-year survival of 50%. So the next tumor we need to talk about is the peritoneal carcinomatosis. Again, specifically from the colorectal cancer origin. So 25% of the colorectal cancer patients will actually develop peritoneal carcinomatosis. And median survival for these patients is 6 months if no intervention is pursued. There was one randomized trial that was done in 2003, which looked at patients with peritoneal carcinomatosis from colorectal cancer, and then compared systemic chemotherapy for one group of patients versus cytoreductive surgery and HIPEC for the other group of patients. And there was a clear difference in survival between the two groups. So for the cytoreductive surgery group, the survival was 21.6 months versus 12.3 months for the systemic chemotherapy group. And this was statistically significant. So really that, since 2003, after the randomized trial, the cytoreductive surgery for peritoneal carcinomatosis had really caught on based on this trial. So risk factors for peritoneal carcinomatosis from colorectal cancer, really it's tumor biology. It's usually the more aggressive tumor compared to some other tumors that may just spread to the liver, because these will eventually spread to the liver as well. But these are usually will have a more aggressive tumor biology and have lower rates of survival compared to other colorectal cancers. Workup, same thing as for pseudomyxoma. You have to get a CT scan of the chest and pelvis to evaluate the extended disease, and that will, based on that, you will decide if this is something that you can cytoreduce or not. And also colonoscopy, because patients may actually present with synchronous metastases. So you need to, they may just come in, and sometimes it's hard to notice the primary lesion on the CAT scan. So colonoscopy would be one way to go if they haven't had one in the recent past. Prognosis for peritoneal carcinomatosis, tumor biology clearly, because tumor biology always wins. Synchronous versus metachronous lesion. So synchronous disease would be more aggressive, will carry poor prognosis compared to metachronous disease. In terms of treatment, you will have to, the completion of cytoreduction will also affect prognosis. This is something that you can completely cytoreduce followed by a HIPEC. Those patients will have a longer survival compared to those that will not have complete cytoreduction. And then one thing that SCORE wants you to know is the extent of disease when you start out, which would be in this case, peritoneal carcinomatosis index. And this is in brief is what PCI score is. So you divide the abdominal cavity into 13 regions. Periumbilical is a 0, and then you start out in a clockwise direction, 1, 2, 3, 4, 5. So these are 9 regions, and then so that you look at inside the peritoneal cavity, and specifically at the small bowel, you start out with the proximal jejunum, then proximal ileum, mid ileum, and distal ileum. So you look at, these are the 13 regions that you have to look at, and look at the tumor load at each of these sites. And in terms of the size of the tumor, if there is no tumor seen, it's a score 0. If the tumor in each of these regions is 0.5 centimeters or less, so that's a 1. So all of these 13 regions had tumors that had tumor less than 0.5 centimeters, so all of these would be 1, and your cumulative score would be 13. But as I said, it could be random. This area 1 may have a tumor that's 0.5 centimeters, but area 4 may have a tumor that's greater than 5 centimeters. So the score for that would be 3. So the maximum score, if all of these regions had a 3, would be 39. So that's what you're looking for, and this will give you an idea of the tumor burden, and that affects the prognosis. So if you have a higher tumor burden, if somebody has a PCI score of 39, of course, their prognosis would be worse compared to someone that has a PCI score of 30. So that's a very important prognostic factor that you need to know. That score, I was a little surprised, but score mentions that, so you guys need to know. And important thing in this setting, compared to the pseudomyxoma, there really isn't much of a role for systemic chemo, because there's no systemic chemo that really makes a difference. But for peritoneal carcinomatosis from colorectal cancer, systemic chemotherapy also has a role in conjunction with the cytoreductive surgery. And the other thing that we talked about, the completion of cytoreduction also being prognostic factor. Just quickly, ideally you want to get R0 resection, which would be no residual disease, or even R1 is acceptable where you have positive microscopic margins. Because in both these settings, the tumor burden that's left behind is, as we talked about, less than the 2 millimeter cutoff, which is shown to allow better penetration of the chemotherapy. So ideally you want to shoot for either R0 or R1 resection. R2A would be any gross disease that's less than 0.5 centimeters. R2B is anywhere between 0.5 to 2 centimeters. And 2C is gross disease greater than 2 centimeters. So classically anything R2A or above, the chances of chemotherapy penetration from a HIPEC standpoint is not that great. So ideally, what you should shoot for is R0 or R resection, which would allow better penetration of chemotherapy. So let's go over the scenario real quick. So 60-year-old patient with, in order to have synchronous peritoneal carcinomatosis from colorectal cancer, what would be the next step? Lloyd, what would you do? So we already have it. So the patient presented with abdominal pain, he got a CT, there was concern for peritoneal carcinomatosis, and let's say they did a colonoscopy, found a primary colon cancer in the right colon. So our presumed diagnosis at this time is probably this is peritoneal carcinomatosis from colorectal origin. So what's the next step? So in this case, that's why I said systemic chemotherapy has a role. So, yes. So again, many different ways to do it, but the way I was trained, and most people will tell you, because you don't know the tumor biology here. As I said, if this is a synchronous disease, which means it just starts out being more aggressive. So you want to try a round of chemotherapy, see what the patient does on that. If whether the disease stays stable versus disease actually spreads or gets worse. Because in that case, then patient wouldn't benefit from a big surgery like this if there is aggressive tumor biology. So you start out with systemic chemo, probably, depending on this, you'll have to talk to your oncologist either 6 weeks or 3 months or whatever, and then get periodic CT scans, depending on, figure out how the the patient responding to it, and then based on that, if patients had a good response or at least the disease stable, then yes, you can proceed with HIPEC, but don't just jump into it right away. So that's the difference between this and your pseudomyxoma. Pseudomyxoma doesn't have good chemotherapy. So as long as you feel on CAT scan you can get most of it, you just jump into cytoreduction surgery. But this is a little different to the colorectal cancer, peritoneal carcinomatosis. 60-year-old patient with previous history of stage 3 colorectal cancer, status post resection and chemotherapy 3 years ago, now has peritoneal carcinomatosis on CT scan. How would you proceed in this case? Ronnie? Would your approach be any different to synchronous lesions?
In this case, you could make the argument that at this point they have peritoneal carcinomatosis, they need a HIPEC. But on the other hand, the question you just said, like, if they worsen with chemo or they have recurrence, then they may not respond to that. Because if they didn't even benefit from chemo, it's basically progression of disease. Give them a very morbid procedure without.
So you would do chemotherapy up front or no?
Yeah, I guess in this case you could give chemo again, see if they.
Yeah. But is there anything else you would want to do?
Besides restage, they've obviously done that.
You've already done the restaging, yeah. But is there anything else you would want to do? Specifically, now that you have a lesion 3 years out. So the one thing you got to rule out is if there is a new lesion. Probably I would repeat a colonoscopy again. Don't just assume that it's coming from the previous cancer that's already been resected. So that's an important step. You got to repeat a colonoscopy, figure out if there's a new lesion, because that may need to be resected as well. And yeah, I agree with probably chemotherapy up front, and then do the cytoreduction surgery. So the last tumor we're going to discuss are the desmoid tumors. And so desmoid you can find either on the abdominal wall or the mesenteric. So the mesenteric desmoid tumors, 10% of all sporadic desmoid tumors are of the mesenteric origin. Important written board question is, the sporadic desmoid tumors have beta-catenin activating mutation. And so that's probably, you'll see that on your written board, that the sporadic tumors have beta-catenin activating mutation. Other risk factors for desmoid tumors are FAP, as well as previous abdominal surgeries. If patients have tendency or genetics, again, it's really hard to explain, but some patients have had previous abdominal surgery with subsequently developed desmoid tumors. In regards to FAP, 10 to 15% of patients with FAP will develop desmoid tumors. Of these, 70% are intra-abdominal. Other sites include abdominal wall, which is the second most common site. And if patients have a family history of desmoid tumors in FAP setting, up to 25% of those individuals will develop FAP, will develop desmoid tumors if they have a family history. Presentation, usually it's abdominal pain, which could be from the bowel obstruction or the bowel ischemia. Can involve bowel extensively, these tumors, especially the root of the mesentery, in which setting they may be difficult to resect. Can also involve the ureters. Desmoid tumors usually are multiple, especially the intra-abdominal ones. Workup would be your CT scan to again determine the extent of disease and the location, whether this is resectable or not. Surgery is recommended for tumors that are well defined and have clearly resectable margin. So we talked about if they involve the root of the mesentery, probably not a good idea to resect, because that would involve resecting all of the small bowel, which then is not compatible with life. They do have a high recurrence rate even after resection. So depending on which paper you read, the recurrence rate is from anywhere between 57 to 86%. For advanced disease that cannot be resected completely, there's several treatment options. You can do NSAIDs tamoxifen, and Gleevec. Those are some of the treatment options that are used for advanced disease. Even in setting of advanced disease, overall, they have a 10-year survival rate of anywhere between 60 to 70%. So even for the advanced disease patient, will still have a relatively, they'll survive for a relatively long time, even the advanced disease. But, adding Gleevec or tamoxifen and stuff may even add a few more years to that. That's pretty much it. You guys have any questions?
If you had somebody come in with CT scan showing involvement of the root of the mesenteria, would you take them back at all, at least to take a look and explore and see, could you get this out without resecting a ton of small bowel, or would you leave it alone and saying?
That's your option. So that's certainly an option. You can explain to the patient that this looks like the root of the mesenteria is involved. Unlikely they will be able to resect, but we can certainly, especially if it's a young patient and stuff, you say, we can certainly go in and take a look if it's possible. We'll try and do it. So it certainly wouldn't be a bad option. But go to warn the patient ahead of time. We may not be able to. Questions?
Dr. Ahmed? Dr. Ahmed?
Yes.
On the case where if somebody presents with, you said colorectal cancer and peritoneal carcinomatosis on a CAT scan, you were saying that chemo has a role in PC. Would you still resect the primary tumor, or you do neoadjuvant and then later resect the primary tumor and maybe do cytoreduction?
I would start with systemic chemo first, and then based on the response, then worry about resection.
Yes, sir.
Now, even if it's not resectable, but there is concern that this could develop into an obstructing lesion, you can take the patient back and try and resect or do a stent or whatever, but systemic chemo ideally. So it's similar to, again, like, if you have a patient presenting with metastatic disease to the liver, there are two approaches. Some people may want to take the patient to the operating room first, but some people would say do systemic chemo because it's metastatic disease. Same approach, even with peritoneal carcinomatosis. Again, this is a more aggressive disease, so I would, at least my approach would be to do a systemic chemo, and then based on the response, then determine if cytoreduction is possible or not, and worry about resection at that time.
Going at 8:30.
Thank you.
And then
All right, thank you.